Jillian Spencer, the only one of our speakers from Brisbane. Jillian studied medicine at Monash University, and she moved to Brisbane to complete her internship in 2002. She trained as a psychiatrist and completed subspecialty certificates in child and adolescent psychiatry and forensic psychiatry. She's worked as a psychiatrist since 2009. She has no political or religious affiliation. She's very concerned about the affirmation model that is being used to treat children with gender dysphoria. Jillian's had a lot of publicity and some media recently, and I said to Jillian a couple of weeks ago, you're like that little girl. You know the story of the emperor who had no clothes, and he went in a procession and everyone was complimenting him and saying how wonderful his clothes were, and a little girl piped up and said, the emperor has no clothes on. And I see Jillian that way because Jillian has ignited something within her profession. Please welcome Jillian Spencer.
I find it really hard to understand how we got to this point. It seems to me that in most other areas of life, as a community, we've been increasingly worried about health and safety. Bike helmets became compulsory, cigarettes became expensive, put behind the counter, into plain packaging. We're all used to hearing the safety announcements at the Brisbane airport to hold on to the handrail, and in Kmart to not let your kids stand up in the trolley. So it's understandable to me that modern parents have been blindsided, and sadly many more will be blindsided by the realisation that there are dangerous ideas being pushed at children, and if their child is influenced and they seek help, parents may be unable to prevent the harm as a consequence of the treatments that are provided. There are thousands of devastated parents across Australia who are hiding their own pain in order to stay close to their child who has gender dysphoria. They fear that expressing their concerns will make their child pull away, and in turn this will cause their child to walk further down the affirmation pathway that so many people are encouraging them to do. It is an incredibly difficult situation for these parents who are sailing in uncharted waters in trying to protect their child from this very modern threat. So I have my own public safety announcement, which I'd love to hear broadcast at the airport or in Kmart. And it is this: parents, please very carefully screen the mental health clinicians that you allow to engage with your child. It is recommended that you meet with the clinician beforehand to check that you are comfortable with the approach that they will take. As you might have heard me say before, there is currently an awful lot of pressure on child psychiatrists and other mental health clinicians to affirm children. There's also a generation of younger mental health clinicians who have been taught the affirmation model and have not yet questioned it, despite all the international developments. Currently, health professionals are keeping quiet about their concerns out of fear, and this is creating a false impression that everyone thinks the affirmation model is a good idea. This conspiracy of silence is having a serious impact on the care being provided to children in mental health services. My concerns when working in the hospital were not just about all the trans pride flags in the waiting room and the rainbow lanyards and the pronoun and ally badges. I was very concerned because I noticed that mental health clinicians felt unable to consider a child's gender dysphoria as part of their mental health presentation. When I say this, I'm talking about the mental health teams working across the entire district. So these aren't just the mental health professionals working in the gender clinic. For example, mental health clinicians would talk about a 12-year-old who identifies as a boy with anorexia, or a 14-year-old who identifies as a girl who had overdosed. The focus would be on the anorexia or the overdose, never on the gender dysphoria. It was never considered that we should try to help the child recover from the gender dysphoria. It was like we were all pretending that this child had changed sex. No one felt able to think about why the child felt so uncomfortable in their own body, or why they felt more comfortable identifying as the opposite sex. I felt concerned that we were providing a very poor standard of care. Also, I can't tell you how disturbing it is to be with colleagues each morning in a handover meeting, discussing patients, and for everyone to be anxiously trying to keep up this pretense. But of course, it's really hard to do, and the truth would slip out, and someone would always accidentally use the child's biological pronouns and be embarrassed and apologetic. I understand that back in the 1990s, there were researchers around the world, particularly in Amsterdam, who were noticing that transgender adults were not faring well physically and mentally. And the researchers speculated that the negative outcomes in transgender adults were due to not passing as the opposite sex. So they planned to try to change the ultimate cosmetic outcome by blocking the puberty of children suffering gender dysphoria. These researchers seem to have forgotten, or they disregarded, what was already known from the 11 studies from before the affirmation model, from the time when puberty blockers and cross-sex hormones were not in use. These studies showed that the majority of children, 60 to 90%, recover from gender dysphoria through the course of adolescence, and a significant proportion of them end up being gay or lesbian. The original study conducted by these Dutch researchers had major flaws, such that the findings are considered biased and unreliable. They studied a group of 77 children who had demonstrated cross-sex identification from early childhood. They gave the children puberty blockers, cross-sex hormones and gender surgeries. One of the cohort died from the complications of a vaginoplasty. They called their intervention the affirmation model. And from this flawed research, the affirmation model leaked out of the Dutch lab and avoided being subject to high-quality clinical trials, and was gradually adopted into clinical use across the Western world. The affirmation pathway as it is now practiced is to encourage all children to contemplate their gender, and then when a child develops or presents with gender dysphoria, they are considered to be gender diverse, and they are encouraged to socially transition. The family are firmly encouraged to support the social transition on the grounds that it is a life-saving approach to prevent suicide, even though there's no reliable evidence that social transition, or indeed the entire affirmation pathway, improves psychological outcomes or reduces risk of suicide. Social transition prevents a child from recovering from gender dysphoria. It gets the child to feel comfortable presenting as the opposite sex and makes it harder for them to see themselves in their biological sex. And at the time when this is happening, the child is not able to understand that to continue presenting as the opposite sex, they will need to embark on a medical and surgical pathway right from the very cusp of adolescence, which is lifelong and has very serious consequences like infertility, affects their sexual function, and has a range of health problems. The first step in the affirmation pathway is this. Puberty blockers are prescribed at the very start of puberty, Tanner's stage 2, which is aged 10 to 12. Puberty blockers are originally conceptualised as giving children time to think before starting irreversible interventions. However, what is known from their widespread use is that puberty blockers prevent the child from recovering from gender dysphoria. There is a high rate of continuation onto cross-sex hormones and then onto surgery. So instead of 60 to 90% of children becoming comfortable in the body through the course of adolescence, more than 95% go on to take cross-sex hormones. The side effects of puberty blockers are similar to menopausal symptoms: fatigue, hot flushes, mood problems and weight gain. Puberty blockers cause reduced bone mineralisation at a time of life when the bones are meant to be reaching their peak density. There are suspected cognitive and emotional impacts through blocking puberty, and last year the FDA added a warning label to puberty blockers for a serious condition that raises intracranial pressure. Also, it isn't quite so easy to just restart puberty after a few years on a puberty blocker. If the full affirmation pathway is followed as recommended, because of the treatment, the person will be infertile and their capacity for sexual pleasure will be affected. Depending on their biological sex, the cross-sex hormones are associated with health risks. For example, there is higher cardiovascular morbidity amongst females taking testosterone and high rates of some cancers and strokes from venous clots from males taking estrogen. There are general risks that come with all surgery and specific risks related to the complications from gender surgeries. There is a particular risk for boys who, due to the puberty blockers, will not have enough tissue, so will require the use of the colon for the vaginoplasty, which is a much more dangerous procedure. And as I mentioned before, this is how one child out of the original 77 Dutch cohort died.
Excuse me, did you say use of the colon for the vaginoplasty?
Just a segment of the colon, sorry, not the whole lot.
Yeah.
So how did the affirmation model come to Queensland? My understanding is that a growing number of referrals led to the Queensland Children's Gender Service being set up and seeing patients by June 2017. The clinic was set up within a medical framework such that the children's clinical notes are put into the medical electronic clinical record. They are not documented within the separate mental health electronic clinical record. And this reflects the ethos of the clinic, that these children attending are transgender and they need medical intervention. They are not considered to be suffering gender dysphoria, which is a mental health condition requiring mental health care. The growth of the gender clinic was reportedly about 15% per year in the first 3 years, but amidst the pandemic in June 2020, referrals started doubling every month, and that continued throughout 2021 and 2022. And to manage this, the gender clinic has extended its hours, introduced Saturday clinics, and sees kids via telehealth. In 2022, the clinic had a staff-to-patient ratio of 1 staff member for every 70 child patients. Now, this is really different from a child and youth mental health service, which provides multidisciplinary mental health care, where you would expect a staff-to-patient ratio of about 1 to 20 or 1 to 25, or even fewer patients per clinician for more intensive teams, which are for children with very complex mental health issues. The model of the gender clinic is that it does not provide ongoing mental health treatment. If children are considered to require ongoing psychological work, they are referred out to private psychologists who are known to take an affirmational approach. However, staff at the Tavistock in the UK noted that once children are on puberty blockers, it is really difficult to get them to engage in therapy to work on their gender dysphoria. So following their initial assessment, children attend the gender clinic about once every 3 months for their puberty blockers or hormone prescriptions. And from what I've seen, the gender clinic will provide support during these appointments to assist the child to come to terms with being trans. If the child has doubts about being trans, these doubts are reframed as internalised transphobia, and the clinic will speak to the child's family to encourage them to support the child's transition. The gender clinic acknowledges that they think gender care starts in schools. The clinic has put a lot of effort into providing education to the school-based health nurses and guidance officers across the state regarding how to affirm and socially transition children. When the gender clinic uses language like statewide capacity building and building an entire service network, they mean arranging for doctors in other hospital and health districts to prescribe puberty blockers. We are lucky because recently, in a response to a request from the gender clinic to expand the prescribing of puberty blockers, the Queensland Health Medicines Advisory Committee restricted the prescription of puberty blockers to those children who are engaged with the hospital gender clinic. It's a small win. A key strategy by the gender clinics has been to falsely claim that the affirmation model prevents suicide. There is no reliable data that the affirmation model reduces suicide risk in children with gender dysphoria. Actually, there's some research which may suggest that there's an increased risk of death by suicide amongst children receiving gender-affirming care. For example, a National Institutes of Health multi-centre study in the US, published in 2022 by Chen et al., of 315 children receiving gender-affirming care over 2 years, had 2 children die by suicide and 11 develop suicidal ideation. And this was a study where any suicidal children were excluded at the start of the study. So any health professional or doctor who tells a parent that they are at higher risk of losing a child to suicide if they don't affirm them is wrong. And maybe they should be removed from clinical duties. My experience working in the health system was that I felt surrounded by a very large quality and safety bureaucracy. There were constant audits and accreditation processes. We had to complete mandatory training modules in speaking up for safety. Despite this, trying to raise concerns about the safety of the affirmation model over a sustained period led nowhere. Raising concerns externally through avenues like the Children's Commissioner, the Office of the Chief Psychiatrist, the Executive Director of the MATODS branch, and with the Health Minister's Office also led nowhere. The Chief Psychiatrist advised that the appropriate avenue was the Office of the Health Ombudsman. Last week I received a response from the Office of the Health Ombudsman regarding a complaint I made to them earlier this year about a child who was prescribed puberty blockers after 2 assessment sessions at the gender clinic. Unfortunately, the Office of the Health Ombudsman reports shows that they don't want to, or they don't have the ability to assess the quality of research studies. They have fallen hook, line and sinker for the claimed results of the biased and flawed studies provided to them by the hospital. In the Office of the Health Ombudsman complaint, I also raised concern about the gender clinic's written consent form, which tells parents that, when puberty blockers are appropriately prescribed, they can greatly improve mental health and quality of life. I advised the Office of the Health Ombudsman that there is no evidence that puberty blockers improve mental health or quality of life. They responded by saying that because Stephen Stathis had said on 4 Corners that he was reviewing the gender clinic consent form, no further action was required. So the Office of the Health Ombudsman is relying on glib statements made on a television program as a source of information about hospital processes, and that they appear to be naively leaving it up to the hospital to correct course. Given the international developments in this area, I would have thought that the Office of the Health Ombudsman would be clamouring for an opportunity to properly investigate and assure themselves that the interventions being delivered by the gender clinic provide benefits to children that outweigh the harms. On their website, the Office of the Health Ombudsman says that they exist to protect the health and safety of the people of Queensland. They are clearly currently not capable of doing the job that they exist to do. So how do we get out of this? We need to change our approach to supporting children with gender dysphoria. All adults, but especially teachers and health professionals, need to take a united front when we meet children with gender dysphoria. We need to say to them, we understand that you're feeling really distressed and you're very uncomfortable in your body. We will do everything we can to support you through this. But the risks and long-term consequences of transition are so serious that we cannot just assume that transition is the right way forward. Because of this, we are going to continue to use your birth name and pronouns. We will work with you to understand what you are going through and look at all the ways we can help you to feel better. I don't think we can leave it to the health services to pull back by themselves, and I don't think that organisations set up to monitor the safety of health services are up to the job. Which is why we need to campaign for an independent federal inquiry into treatments provided to children with gender dysphoria in Australia. So just to finish up, in terms of supporting me, there are a couple of ways. One is to communicate to the Board of Children's Health Queensland via the Chair, Mr David Gow, which is spelt G-O-W, that we do not want our public children's health services to use the affirmation model. And also we should tell him that clinicians concerned about the affirmation model should not be removed from clinical duties. The second way is to try and distribute the flyer which I've made, which instructs doctors on how they can join me in my call for an independent federal inquiry. And the third is when the call is put out for financial support, which would come via the Human Rights Law Alliance, if you can donate. I've got a legal case which is a Human Rights Commission complaint, and that's because I believe that it needs to get escalated up into an open court to decide if organisations such as Children's Health Queensland are able to mandate its staff to always use the preferred pronouns of children and compel them to always take an affirming approach towards children with gender dysphoria, and to always refer gender questioning children to the gender clinic. And just finally, I'm proud and happy to be part of a group in Australia trying to set up GenSpect in Australia, and if anyone wants to join, they can. Joining us via the international website. But thanks for listening. Thank you.
Thank you, Jillian.